All right, it is 12 o'clock on the dot, so let's go ahead and get started. Good afternoon, everyone, and welcome to our Department of Medicine Grand Rounds. My name is Ryan Abe, and I'm one of the Medicine Chief Residents. Today, I have the pleasure of introducing our Grand Round speaker, Dr. Mark Werfel. Dr. Werfel is a professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine, and holds the David J. Pearson, MD, Professorship in Pulmonary and Critical Care Medicine. After graduating from the University of Michigan with a degree in economics, he obtained his MD from Cornell and a PhD in immunology from Rockefeller University in New York City. He came to the University of Washington for his residency in internal medicine and stayed at UW for a fellowship in pulmonary and critical care medicine. He currently attends on the MICU, TICU, and pulmonary consult services at Harborview, and directs a translational research group based at Harborview that studies the molecular and genomic risks for organ failure and death in critical illness, and most recently in COVID-19. He's going to speak with us today about critical illness and COVID-19. So without further ado, I will turn the stage over. Thank you so much, Dr. Werfel, for joining us today.
Thank you, Ryan.
To the group, I'll just say one quickly, for the audience, please post your questions in the chat, and I will pose them to our speaker at the end of the presentation. So thanks.
Okay. Thank you, Ryan, and thanks to the organizers for inviting me to talk. So as stated, today I'm going to talk to you a little bit about what we've learned as far as critical illness in COVID-19, and I'm going to talk a little bit about how we incorporate some of what we've learned and ideally, as we move forward, ideally beyond the pandemic, how we might use some of that information to treat people outside of COVID-19. This is my disclosure slide. There's no conflicts relevant to this talk. So I know many of you have cared for COVID-19 patients. Many of you have cared for patients in the ICU. I would note, actually, before I go on, that January 21st is the 2-year anniversary of the announcement of the first case of COVID-19 in the United States here in King County. So wasn't planned, this talk, but to be on the anniversary, but maybe it's appropriate. Anyway, getting back to my talk. The case I want to describe to you is something that we saw early in the pandemic in March of 2020, and it's the case of Bess Doe. She was an obese woman in her 50s who was found down, unresponsive. She was intubated by the medics for airway protection and hypoxemia. Her ED course was notable for her being in shock, very tachycardic, started on vasopressor, norepinephrine drip. She had a head and body CT, primarily because there was a concern for an acute stroke, but as we see later, it was identified that she had bilateral pulmonary opacities. Notably, her family said that she had had flu symptoms for about a week prior to presentation and that she had a history of diabetes. When she was evaluated in the ED, she had an ABG that showed that she was quite hypoxemic with a PaO2, FiO2 ratio of less than 100. She had an elevated lactate, elevated anion gap. Her CBC was notable for mild lymphopenia. Her coags were also mildly abnormal. Her LFTs were normal. And as I mentioned, as shown on the right, she had a chest X-ray that shows hazy bilateral opacities that were very much confirmed on the CT chest shown below, with diffuse alveolar filling process, in some place, very, very dense consolidation. She was aggressively volume resuscitated, started on broad spectrum antibiotics. As I mentioned, she was on vasopressors and those were escalated. It was attempted to place her on lung protective ventilation given that she qualified for severe ARDS, but she didn't tolerate this because of severe acidosis. She was initiated on hemodialysis for aneurysm renal failure and that severe acidosis. In terms of how she progressed, it became kind of a familiar story, unfortunately. She had an unsupportable shock and hypoxemia, and she died within 48 hours of admission. I would note that at this point very early in the pandemic, we weren't doing ECMO for these sorts of cases. Later on in the course, she might have qualified for that. I think it's obvious, given the topic of the conversation here, that this was ARDS and septic shock due to SARS-CoV-2 infection. And I think, unfortunately, it was indicative of a lot of what we then saw as we move forward. So in case you hadn't kept track, the pandemic is still ongoing. This is pulled from the Johns Hopkins website a couple of days ago now, noting that there are over 300 million cases and over 5 million deaths. Unfortunately, in the state of being, the U.S. is number one for deaths, cases and deaths. And I think it's clear that there is an ongoing need for better understanding of how we deal with COVID-19. In particular, critical illness is common. So as I'll get to later on, approximately 5%, 5 to 10% of the patients who come into the hospital end up needing intensive care management. As you can see, this is drawn from the Oxford University website that pools data from all over the world. And again, you can see that the United States is leading the world in terms of ICU bed utilization, commonly exceeding 25,000 on any given day, and much higher than other very well developed nations. This is just a snapshot of a couple of days ago in the setting of the Omicron surge. And what you see is that there were 67,000 total ICU beds in use in the United States, and that about 26,000 of those were taken by patients with COVID-19. So I think even though Omicron is decidedly less likely to put you in the ICU, the sheer numbers have resulted in an ongoing burden within the ICU. And again, this just highlights the fact that COVID-19 puts a very large burden, both in terms of resource utilization and just the sheer amount of effort from physicians and staff to care for these people. So I'm going to talk about several aspects of critical illness in COVID-19 and really talk more generally about how we might use what we've learned going forward. I'll give a brief overview of what critical illness in COVID-19 looks like. I'll talk about probably one of the most commonly talked about things for the first 6-10 months of the pandemic, the cytokine storm paradigm and whether it's useful. I'll move on to a discussion of COVID-19 ARDS and how we might learn something from how we saw acute hypoxemic respiratory failure in the pandemic, how we ran trials for it, and how we might be more inclusive of patients as we move beyond COVID-19 pandemic. And then I'll give you a little summary. So what is critical illness in COVID-19? So as you know, Seattle was one of the first sites to really see a surge in severely ill COVID-19 patients. As many of you might remember, in particular, there were nursing homes that were hit hard. And obviously the patients who were in those nursing homes were at very high risk of severe disease, being aged and with comorbidities. So actually the figure there on the right is taken from a New England Journal article that Pavan Bhattraju published early on that described the first 24 patients that we saw here at UW Medicine and Swedish Hospital. So critical illness was seen in about really over 25% of the COVID-19 hospitalizations at that point. As you probably all know, it was enriched heavily for patients with obesity, chronic respiratory illnesses, chronic kidney disease, and diabetes. Severe hypoxemic respiratory failure requiring mechanical ventilation occurred in about 75% of the people who were transferred to the ICU. Shock was common, as was seen in the vignette before, about 70%. Acute kidney injury was seen in about 30%. Early on in the pandemic, the mortality was particularly high, somewhere in the 50% range. And the median ICU stay was, for survivors, was 2 weeks. So it was already shaping up to be a very, very difficult situation as far as the ICU went. So how did this play out over time? So this is from the virus registry, a group of hospitals put together through the Society for Critical Care Medicine. This data from 168 hospitals in 16 countries, though primarily from the United States, between February 2020 and November 2020. So this is giving you a picture of how the critical illness pandemic evolved over the months following that initial description from Pavan. So as you can see, the patients were similar in that they were predominantly male, they were predominantly obese. There was a high burden of comorbid conditions, particularly diabetes, hypertension, and chronic kidney disease. The hospital length of stay was about a week, though if you ended up in the ICU, your length of stay was considerably longer, on the order of 2 weeks, similar to what Pavan had described. The mortality remained high, in particular for people who were above 75 years of age, which was a large portion of the initial group that we had seen here in Seattle. The mortality was over 50%, although the overall mortality as it evolved was closer to 35. A high proportion of those hospitalized and ICU bound were mechanically ventilated as expected. As you can see, if you look at the outcomes, in particular the mortality, as you add on the level of organ support necessary, so no organ support necessary, you see that the mortality is in the 10 to 20% range. As you progress through to a patient similar to the one I initially described on mechanical ventilation, renal replacement therapy, and vasopressors, the mortality is in excess of 70, 80%, very, very high mortality. And so this was after, this was several months after the initiation of the pandemic. We had already learned something about how to treat it, but the mortality and the burden in terms of organ support needs remained high. So I could go on and on, that there's literally tens of thousands of reports on the epidemiology of COVID-19. But I just wanted to get you up to speed briefly. So I want to move on to why we care beyond. So you're not a ICU doc that focuses on COVID-19. You want to take care of other patients in the future. Hopefully we're moving beyond the pandemic. I think it's really important for us to look back on what we've done, because we've done an enormous amount, both in terms of basic and translational research, and then an enormous amount of clinical trials have been completed. Probably in the hundreds of thousands of participants have been enrolled. So what can we learn from this? We really need to take something forward. So I think it's important that this is a novel pandemic. It's beyond that initial phase where we were all very scared and had no idea what to do. But I think just thinking forward to another novel pandemic, we have to try and evaluate what might be repurposed, right? So we have a lot of information about what we had tried in the past for ARDS, for sepsis, et cetera. What does COVID-19 look like? Does it look enough like what we've seen before in critical illness that we might be able to apply some of what we've learned? We really need to think about this for the post-pandemic era because we're going to go back to very full ICUs as we saw just a couple of months ago before the Omicron surge happened. Our ICUs were full with non-COVID patients. So this is going to happen again. What can we learn from all that we've learned in COVID to treat the non-COVID patients? And I think, again, importantly, we will see another pandemic, unfortunately. Maybe not in my lifetime, but it'll happen. And we need to develop ways, sort of paradigms to more quickly understand what's happening and implement processes that might save lives. So in comparing and thinking about what makes the most sense to compare with, I think COVID-19 in general is a form of sepsis. And so I think it makes a lot of sense to compare what we've seen with COVID-19 critical illness to pre-COVID sepsis. And there are some basic things to understand and some differences that are notable. So obviously in COVID, we have a very homogeneous population that I think actually made for a much better research effort because rather than trying to understand the heterogeneous processes that might be involved in general sepsis populations, we had a single pathogen. And so at least it would be hoped that some of the processes going on would be more uniform. Respiratory failure, very common, both in sepsis admitted to the ICU and in COVID. As I'll talk about, we saw a considerable amount of shock. I should say that within the respiratory failure, one potential difference between the form of respiratory failures we've seen in COVID versus sepsis is that COVID is primarily a direct form of ARDS. That is to say, SARS-CoV-2 is directly affecting the respiratory epithelium and causing inflammation and damage within the lung. Whereas in sepsis, although a large proportion of sepsis cases that we see are direct injury from most commonly pneumonia, bacterial pneumonia, there are a significant number of cases that have ARDS secondary to some process such as abdominal sepsis. So there are slight differences that you would expect between the two. Shock, question of whether cytokine storm might be applicable, and I'll talk about that a little bit more. Renal failure, common in both. Evidence suggests that they're both most commonly ATN. CNS dysfunction, a lot of drugs given to facilitate all the things that we need to do. Delirium, very common. Critical illness, polyneuropathy, myopathy, probably quite common, although I don't know that we know very specifically what the prevalence and incidence of that is in COVID yet. Coagulopathy, there was a lot of talk about this up front, this concept of endotheliitis, microthrombi formation in COVID. I think that may have been a little bit overblown because many of us understood already that there's a large degree of endothelial dysfunction that goes on in run-of-the-mill bacterial sepsis. But I think some of the histology that's been seen in COVID does suggest that the microthrombi component may be more prominent in COVID than run-of-the-mill sepsis. Cardiac dysfunction, common. Liver dysfunction, relatively rare, although we saw it. Long-term sequelae. So already it had been well known that after severe sepsis, a long ICU stay, that PTSD, weakness, some cognitive challenges were common. In the COVID setting, I think we've heard a lot more about it, and that some of that may just be because of public awareness. But there is certainly some evidence to say that the so-called long COVID syndrome exists, and that it has multi-organ involvement. The organ that I think we've been particularly interested in, and I think definitively is more involved than run-of-the-mill sepsis, is pulmonary fibrosis. Post-COVID pulmonary fibrosis is not common, but it does occur, and when it occurs, it can be quite severe. Finally, I'm not going to talk about it much today, but a lot of my prior research history has been in genetics and genomics. What we've seen in COVID is that the genetic risks for COVID susceptibility and to susceptibility to critical illness is very strong. There have been multiple genome-wide studies that have all focused in on a locus on chromosome 3 that contains several chemokine receptors and chemokines and proteins that respond to early antiviral response that show replicable, very strong associations with outcome. Part of that may just be, as I mentioned, we have a single etiology, so the phenotype is more pure. But I think we're going to hear more about that as time goes on, and what influence it might have on therapy. So as I alluded to, I want to talk a little bit now about the cytokine storm paradigm. Is it real, and how have we used it? Has it been useful? So this figure is from a review that was published in 2020, early on in the pandemic, describing the concept of cytokine storm. As many of you probably know, much of the literature, recent literature about the concept of a hyperinflammatory state came out of the CAR T-cell therapy literature. Cytokine response syndrome, CRS, as a dreaded complication of CAR T-cell therapy, and results in elaboration of the so-called cytokine storm with multiple different inflammatory cytokines, chemokines, both type 1 and type 2 interferons. And most importantly, some literature documenting that blockade of IL-6 in particular with tocilizumab, which I'll talk about a little bit more in a bit, successfully treats this cytokine storm in response to CAR T-cell therapy. And I think really pushed some of the early interest in cytokine storm in COVID-19. So what is cytokine storm? There are multiple different criteria, and so I'm not going to belabor the point. I think it's very nonspecific in terms of its clinical presentation. Looks a lot like sepsis, fever, fatigue, headache, tachycardia, shock. All organs can be involved. I think from a laboratory standpoint, the sort of standard things that we look for are evidence of elevated ferritin, potentially elevated triglycerides in the setting of HLH. But fortunately or unfortunately, the true definition of cytokine storm is vague. So what early evidence was there that cytokine storm actually existed in COVID-19? So this is actually a study that came from Mount Sinai. As you all know, Mount Sinai and many of the New York hospitals saw a huge initial surge of COVID-19 patients, many of them critically ill. They did a great job of capitalizing on those big patient populations, enrolled a lot of patients and studied them well. So this is over 1,900 patients that they looked at in terms of early cytokine responses. This is very simple. They compared healthy donors against patients with COVID-19, and then patients who had received CAR T-cell therapy and developed CRS or didn't develop CRS. So sort of taking the prior well-published, well-documented example of a cytokine storm and comparing it with COVID-19. And as you can see, there was certainly an elevation in IL-6, very, very wide distribution of responses. And if you compared it against CRS in the setting of CAR T-cell therapy, it was comparable, but nowhere near as high in terms of the mean. There were some other cytokines that they looked at, like IL-8 and TNF, that actually were comparable, though not higher. But importantly, these studies were done against COVID-19, not other forms of critical illness. So what this is saying here is that critically ill patients with COVID-19 have elevated IL-6. This is not necessarily saying that COVID-19 in particular has a critical illness phenotype that is enriched for IL-6 and other cytokine production. Anyway, this evidence, along with multiple different studies that measured IL-6 early on in the pandemic in COVID-19, really prompted an interest in using blockade of IL-6 processes with drugs like tocilizumab in severe COVID-19. And I'm sure many of you were part of the discussions and the often confusing discussions about what we should do with toci in COVID-19 more later. So one of the questions that arose in our group during this time, again, was what's the extent to which COVID-19, critical illness in COVID-19 is actually different from other forms of critical illness. Again, getting back to this concept of really trying to understand what the similarities and differences are so that we can appropriately use or not use, or repurpose or not repurpose things we already know about. So to that end, we created a cohort here at University of Washington called the COVID-19 Host Response and Outcomes Cohort, or CHROME. And this was a cohort of ICU patients that were admitted with suspected COVID-19 at University of Washington. We enrolled at Harborview, UW-Montlake, and UW-Northwest. And as you can see, the enrollment criteria were very simple. You had to have clinical symptoms consistent with COVID-19, respiratory isolation for COVID-19, and to be tested with a SARS-CoV-2 RT-PCR and ICU admission. And so we followed them for the result of their SARS-CoV-2 test, and then divided them into the two populations: critically ill patients with SARS-CoV-2 infection and critically ill patients without. On the right here is some basic characteristics of the patients that we enrolled. So among the patients with the 93 patients without COVID-19 and the 78 patients with COVID-19, we saw that there is a lot of similarity in terms of the age. So certainly overrepresented for older age with a mean age around 54 and predominantly male. We saw that the patients were overrepresented for minorities, particularly in the Seattle population. In particular, among those with COVID-19, as many of you probably know, we saw a very large enrichment for Hispanic or Latino patients. Both were obese. Both had a large number of comorbidities, although there were less COPD patients in the COVID patient population versus not. In terms of the ICU admission diagnoses, quite similar: pneumonia and respiratory failure, was shared at similar levels between the two, as was sepsis. Apache score, interestingly enough, so a measure of severity, was higher in the non-COVID patients than the COVID patients. This is measured on admission. We don't record here what's happening later on, but at least as they presented, they were a little less ill. Amongst the patients that we enrolled, some of them came after some of the data that came out on dexamethasone. So there were about 40% of our patients had dexamethasone. As it turned out, a fairly large number of patients in the non-COVID group had received significant doses of steroids as well for other indications. And the median length of stay, as we had seen before, was actually longer for the COVID patients than the non-COVID patients. So we enrolled these patients, followed them, collected blood early on in their stay within the first 24 hours, and then collected serial samples at 48 hours, and if possible, later on in their course. What happened to these patients? How do they compare? So this is a variety of outcomes that we looked at and compared between COVID and non-COVID. And I should say this was lead authored by Pavan Bhattraju and was published in Critical Care in April of last year, if you're interested in more details. So in terms of mortality, mortality was actually quite similar between the two at about the mid 20% range. As we had seen before, the prevalence of ARDS in COVID-19 much higher. So almost 50% of the cases that we enrolled in the COVID-19 group had ARDS relative to 10% in the non-COVID-19. Other events, interventions were fairly similar. Both had developed shock, both developed AKI and severe AKI at a similar prevalence. Renal replacement was slightly higher in the COVID-19 group, but not much. And actually thromboembolism was very similar between the two. So I think overall, what we took away from this is that that as we might have predicted, ARDS much more common, mortality maybe a little higher, but overall, a lot of the other aspects of critical illness were similar. So we were interested then in what the biologic milieu looked like. And so we measured a panel of inflammatory cytokines, chemokines, as well as measures of endothelial dysfunction in the samples that we collected early on in the course of enrollment. And what I show you here is a funnel plot showing you the full change, essentially. So if you're to this side of the middle line here, you were lower in COVID-19. If you were on this side, on the right, you were higher in COVID-19. And how high in the plot denotes how significant the association was. And importantly, here is the cutoff point for just a nominal p-value of 0.05. Because we were looking at multiple different markers at the same time, we corrected for multiple comparisons. And so the threshold we used was this Bonferroni cutoff of 0.002. And using that cutoff amongst the 24 markers that we looked at, we only saw 3 that were significantly differentially regulated. Importantly, IL-6 was not one of them, nor was IL-8. They did not show, they were elevated, very relatively high in terms of absolute amount, but not differentially present between COVID and non-COVID. Whereas we saw that angiopoietin-2, which we had actually predicted would have been higher in COVID, was actually lower in COVID relative to non-COVID. And that's a measure of endothelial dysfunction. Soluble TNFR1, a measure of inflammation, general measure of inflammation was lower in COVID-19, whereas S-RAGE, a measure of epithelial cell damage, and serum amyloid A, general marker of inflammation, both very high in COVID. We looked a little bit more closely then at a broader range of markers to try to understand really what are some other individual markers that might mark a difference between COVID and non-COVID. And this comes from a manuscript that Eric Morel has in review. The same population, only slightly more samples. And we see that maybe as expected, the interferon response and interferon stimulated mediators are markedly elevated in the SARS-CoV-2 population relative to the negative population. So interferon gamma, CXCL10 or IP10, and another measure of T cell modulation, I guess I would say, soluble PD-L1, all significantly elevated in SARS-CoV-2 relative to the negative patients. But again, when you look at the distribution of IL-6, IL-8, TNF, similar between the two. So in terms of the concept of cytokine storm in COVID-19 as opposed to other forms of critical illness, the conclusion we came to, for the most part here, is that cytokine storm exists in most critically ill patients. There's a signal for antiviral responses in the COVID-19 patients, but the sick patients, whether you had COVID-19 or not, all had evidence of elevated pro-inflammatory mediators like IL-6, IL-8, and TNF. So those were studies that we did looking at individual mediators that we had chosen a priori based on hypotheses that we would have guessed from prior studies in sepsis, ARDS, and other organ failure. But we moved on to a study that looked in a more unbiased fashion at what is different between COVID and non-COVID. So this is work funded by the CDC, the Bill and Melinda Gates Foundation. We were able to do a proteomic analysis using the SomaLogic platform that measures about 5,000 different proteins simultaneously in plasma collected early in the course of illness, again, in the Chrome cohort. And we were able to compare 96 non-COVID with 101 COVID patients in terms of plasma proteome. We looked at the differential presence between the two. And as I'll show you on the next slide, we went on to look at its relationship to outcome. So again, showing you a funnel plot. In this case, there are many, hundreds of proteins that were differentially present between the two. But I think, as may have been predicted from our single molecule analyses, some of the molecules that are most strongly upregulated amongst critically ill COVID-19 patients are markers of the antiviral response. So ISG15, IFIT3, MX1, STAT1, all likely upregulated in response to the antiviral response. There were several markers of general inflammation that were somewhat elevated, though again, IL-6, though markedly detectable, not differentially present. And we just show you some of the top hits amongst the higher in COVID and lower in COVID group. And again, those that are elevated in COVID really largely reflect proteins of the antiviral response. Interestingly, some markers of complement were actually lower in COVID, whether that might indicate a consumption of complement in some way. It's been alluded to in some other publications. We haven't actually looked at this further. If you then take the entirety of the data and subject it to pathway analysis, so say, look at the proteins that are identified as being differentially present, how do they group in terms of their biologic function? we see that the top group or pathway that's overrepresented amongst patients with COVID are proteins involved in allograft rejection. So including STAT1, IL-1 beta. So indicative, obviously, of a lymphocyte response. Many other responses within that might have been expected, including the JAK-STAT pathway. However, these were driven by proteins like STAT1 that we also believe might be indicative of the antiviral response. Again, interferon response overrepresented within the COVID-19 group. Interestingly, there were several groups, including markers of epithelial mesenchymal transition that were lower in COVID. And again, that might be due to injury at the tissue level and a blockade of some of the normal processes from COVID injury. And that's certainly something that we need to look at further. So I think we largely confirmed our bias with this unbiased approach, that there would be overrepresentation of antiviral response proteins amongst the COVID-19 patients who are critically ill, that some of these basic markers of inflammation actually are not different. And we found some novel groupings of proteins that are differentially present that really bear further examination. And I will say there have now been several studies that have looked at high throughput protein measurements of varying kinds in plasma, and almost every one shows ISJ15 as the top hit. So I think there are clearly some very robust findings that can be evaluated in the future. So moving on, how can this help us to understand who is going to get sick and who's not? We used the same data set, but then looked amongst the patients with COVID, what the relationship of these different proteins might be to outcome. And the outcome that we chose to look at was ventilator-free days. So the number of days over a 28-day period that a patient was alive and not ventilated. So more ventilator-free days is good. More time off the vent, alive and off the vent. Less ventilator-free days is bad. And what we found again was that there were a large number of differentially present proteins by ventilator-free days. So amongst the the proteins that were elevated in patients with low ventilator-free days, so worse outcome, we found several proteins, not including IL-6, although IL-6 is present amongst the significantly differentially regulated proteins. It's just not amongst the top 10 in this case. We found several interesting novel findings, though this finding with hepatocyte growth factor, HGF, actually essentially replicates what had been seen in sepsis, that HGF, circulating HGF is highly associated with organ dysfunction in sepsis. And so that was very interesting to see. We also, amongst the elevated proteins, saw that a protein called ANGPTL4, which has been reported as being elevated in influenza, was among the top 10 most elevated proteins in COVID-19, severe COVID-19 with worse outcomes. We went on then to look at how robust those findings might be. So moving beyond Chrome, we sought to validate two of these findings, so HGF and ANGPTL4, in an independent group of 158 patients with COVID in the SARI-PrEP consortium. So this is a multi-institutional consortium funded by the CDC Foundation, followed very similarly to how Chrome was followed. And we saw that similar to Chrome, if you look at HGF individually, we see a strong relationship between elevated HGF and worse outcome in terms of the ventilator, worse outcome in terms of survival. Similarly with ANGPTL4, we saw again associated with worse VFDs and worse mortality. And there's a lot that can be said from a pathophysiologic standpoint about these. The main point I want to make is that there are proteins that are strongly differentially regulated that are novel, that actually ought to be targeted for better understanding in terms of COVID pathophysiology. Nonetheless, there were several proteins like IL-6 that were strongly differentiated, regulated, and did replicate in terms of prior studies that showed that IL-6 does mark people with elevated IL-6 does mark people with poor outcomes in COVID-19. So getting back to the importance of cytokine storm paradigm in COVID-19. So I think what we saw was that there wasn't a lot of evidence that COVID-19 was particularly different in terms of cytokine storm profile, but some of the key features of cytokine storm were detectable in relation to COVID-19 related outcomes. So I think just while this occurred in parallel with a lot of what's described on this slide, I think it did provide some support for the concept that cytokine storm does exist, not unique, but does exist in COVID-19. And so that was really part of the large body of evidence that favored attempting to treat that. And the first reports really came with attempts through IL-6 receptor blockade, in particular tocilizumab. A lot of evidence here. I'm only going to briefly summarize it. This is actually results from a meta-analysis that was published in August in JAMA. So I suggest if you're interested that you go to read this because it really summarizes things quite well. Importantly, tocilizumab and sarilumab, which are described in this meta-analysis, are both blockers of IL-6 receptor, not direct blockers of IL-6. Really, the short version is that toci and sarilumab are suggested by NIH for treatment. None of the known blockers, direct blockers of IL-6 itself are. So it had been used, as I mentioned before, in CRS and CAR T-cell therapy, long history of safety for toci and rheumatologic disease. I show you the recent meta-analysis here. Lots of studies really driven by the recovery trial and REMAP-CAP. But ultimately, after a lot of adjustment for heterogeneity, et cetera, the meta-analysis found that there was a modest signal for improvement in outcomes. Notably, the trials pretty strongly suggested that dexamethasone needed to be co-administered with tocilizumab to identify the benefit, and so that's reflected in the NIH recommendations. So the current recommendations are that patients with rapidly increasing oxygen needs that are already receiving dexamethasone and remdesivir. I should say I'm not going to talk about the sort of early antiviral approaches here. I'm really assuming that the patients I'm taking care of are already, that horse is out of the barn. I'll talk in a second about dexamethasone, but the take-home point is that you need to administer, per the NIH guidelines, you need to be administering dexamethasone and toci at the same time in patients who are getting worse. So I think that was one of the first pieces of evidence that treatment of cytokine storm might be useful. Then enter the JAK inhibitors. So the JAK inhibitors block immune-mediated activation through STATs. In particular, they block activation via in response to IL-6, IL-23, a variety of other pro-inflammatory mediators. Baricitinib, which is a JAK1/2 inhibitor, has been studied now in 2 trials. So, with the hypothesis here that blockade of STAT activation after elaboration of the inflammatory response in COVID-19 would dampen down the inflammation and improve organ dysfunction. So 2 trials, Act 2, over 1,000 hospitalized patients treated in the background of remdesivir and dexamethasone, improved to time to recovery. And then a second trial, Cove Barrier, looked at hospitalized patients who weren't on invasive mechanical ventilation, and then added a small group later that were on IMV or ECMO in the background of remdesivir and dex. And they showed survival in both arms. And that's summarized here. So Act 2 here, showing that overall there was a slight benefit in terms of time to improvement. Interestingly, those with the baseline ordinal score of 6, so more severe in terms of hypoxemia, you saw the biggest differential effect. And in Cove Barrier, while the effect in the overall cohort or the overall patient population was relatively modest, similar to Act 2, if you looked at the patients who were most severely ill on IMV and or ECMO, you saw the biggest improvement in mortality to the tune of about a 40 to 50% reduction. There is one other JAK inhibitor that's been looked at, tofacitinib, in one major trial, Stop COVID. The short of that is that this trial also showed an improvement in survival, respiratory failure, and improvement in respiratory failure. So based on this, the NIH is recommending that patients with increasing oxygen needs who are already on dexamethasone with or without remdesivir should be considered for baricitinib. Baricitinib and toci kind of sit in the same point in the algorithm, and I think there are a lot of arguments on what's better. One of the key advantages to the JAK kinase inhibitors is they can be given orally. And I think that you might say that there's a preponderance of evidence that suggests that these are probably more beneficial in terms of the magnitude of the effect. Finally, dexamethasone, just talk about this briefly, because I think you're probably all well aware, but the basic concept again is that you can block these cytokines with corticosteroids. There was pre-COVID efficacy data. Recovery was a large open label trial in the UK, which showed an improvement in mortality, notably the benefit only seen in those who required oxygen, and a recent Cochrane review that showed a similar relative risk improvement with steroids, and the NIH recommends dexamethasone for all people who have OT2 needs, with or without remdesivir. And so I think taken together, you have 3 different forms of immunomodulation that have been successful in COVID-19. And I think at least provide some evidence that modulation of the cytokine storm is a good target. And I think we can think about moving forward using that potentially in other forms of critical illness. So I'm going to switch gears here and talk a little bit more clinically about COVID-19 ARDS and respiratory failure, and I'll try and finish up in the next 5 minutes. So the COVID-19 ARDS, as I mentioned, ARDS is much more common in COVID-19 in all patients who present to the ICU. If you compare, there's a couple of studies, including one from here, written by Natalie Cobb and others from the Harvard Review group, published in the Annals of American Thoracic Society last year, that compared COVID-19 with influenza H1N1. And broad brush strokes in that study and some others show that there's a slightly higher severity of illness in COVID-19, similar or maybe even milder initial hypoxemia relative to H1N1, similar to worse associated mortality. The findings on imaging, very similar, COVID-19, H1N1, diffuse alveolar opacities, a lot of ground glass, as well as dense consolidation. And if you look at the histology, so this is from a study that looked at histopath in COVID-19 deaths. They found that the histology is very similar to other forms of ARDS in terms of epithelial cell damage, alveolar edema. The notable differences were that there's a lot of microthrombi and mononuclear infiltrates as opposed to polymorphonuclear infiltrates that you see more commonly in bacterial sepsis. So there was a lot of talk about how ARDS might be different in COVID, but I think that the prevailing wisdom now is that for the most part, it's the same as what we've seen before. And so we pushed to do things that we already knew work. I'm going to just cover this briefly. So I think one of the things that this has told us, particularly the steroid trial, where we looked at testing treatment in all patients with respiratory failure, not just treating people with ARDS, very pragmatic approach. And so what we and others have been asking is, to what extent might we need to be more inclusive in our definition of respiratory failure? Because that might allow us to treat more patients, get more people into trials, and ultimately make more people better. So Neha Sathian in the group has been working on an automated approach to identifying ARDS amongst patients in an EMR. So this is work done with a group in the bioinformatics division, Kevin Leibarger and Amelia Yatizkin, as well as Sean Mooney and Sujan. And what they've done is identify respiratory failure in a large group of patients from the UW Medicine admitted with COVID. And what she's done now is identified a reduced specificity or stringency in identification of respiratory failure from the straight ARDS Berlin criteria down to very loose in terms of not requiring mechanical ventilation and no imaging findings. As you can imagine, as you loosen the criteria, you get many more cases. But interestingly, as you loosen the criteria, if you look at the mortality actually doesn't decrease that much, while the numbers almost double. And if you say, how does the definition perform in terms of ability to predict mortality? Actually, the most loose definition is the best of the group. So I think what we've taken away from this is that really rather than focusing on ARDS, I think what COVID-19 trials have taught us is that we really need to be focused on the underlying disease itself, in this case, COVID-19, and that a broader, less stringent approach to identification of people worth treating may be beneficial. And there's a lot of interest in shifting the focus. So in the meantime, what do we do? Well, I think I've told you the main high points of the treatment trials. I will point you to the very well written UW Medicine critical care management protocol written by Nick Johnson in Jamestown in Occam. Definitely look it up. There's a lot of good information in there. Look up the NIH treatment guidelines, but largely other than the immunomodulatory stuff, it's doing what we already know to do in terms of management of ARDS. So I'll just briefly go over this. I think that the long and the short of it is that there's a lot in COVID-19, in the bevy of COVID-19 literature that we can actually take forward to other forms of critical illness, and that it's given us the opportunity to focus in on a very homogeneous underlying cause and identify these potentially useful therapies. And I hope actually as we move forward, we can learn from that and really expand our ability to treat critical illness in general. Lots of acknowledgements. I'm just going to leave this up, but many people at UW, both in our division, nephrology, radiology, AID, med genetics, bioinformatics, people at SARD Prep, lots and lots of hardworking research staff and funding from Bill and Melinda Gates, CDC Foundation, NIH, and Roche Diagnostics. Okay, sorry.
Thank you so much for the excellent talk, Dr. Werfel. Really appreciate it. I think we have time for just maybe one question, and I saw it come through a little bit earlier. If you could comment a little bit on how vaccination plays a role into the outcomes that you're seeing as far as percentage of patients who are critically ill or even on acute care that are vaccinated versus unvaccinated?
Yeah, so it's an easy answer. The people who are getting vaccinated, except for people, the experience at Harborview is different from Montlake, where you have a lot of patients who are on chronic immunosuppression, transplant, et cetera. There are certainly people amongst that population who are vaccinated but inadequately protected and ending up in the ICU. But by and large, the people that we're seeing in the ICU are not vaccinated.
Right. Great. Well, we are right at 1:00 p.m. So I just want to thank you again for an excellent talk, and have a good afternoon and weekend, everybody. We'll see you in 3 weeks for our next Grand Rounds. Take care, everyone. Bye-bye.